Welcome to the ACO Show, where we explore everything that's value-based care and ACOs, or Accountable Care Organizations, and why value-based care can do more good for patients, practices, and society. I'm Sean Cavanaugh, and I'm here with my co-host, Dr. Josh Israel. Welcome, Josh.
Thanks, Sean. And I want to welcome you back to Season 8 of the ACO Show. We are excited to be here with you, excited to have you with us. We have a couple of special announcements for this season. First, you may have already figured out, which is that now we are more than just an audio podcast. You can now spend time with me and Sean Cavanaugh on your mobile or laptop screens, and we really hope you'll join us this year on video. Second announcement is that we're adjusting our cadence, so we'll be moving to one new episode every month, though we may drop additional episodes if there's breaking news to cover. So be sure to check in with us the first Monday of every month moving forward for new episodes, or better yet, subscribe so you never miss an episode.
Third announcement is that we've received our 2024 MSSP results. And if you've listened to this podcast in the past, you know MSSP stands for Medicare Shared Savings Program. That's the program that was created by the Affordable Care Act to have providers come together and accept cost and quality responsibility for populations of Medicare beneficiaries. The reason we have the results now is it takes a while after the end of the year for Medicare to tabulate how ACOs did in spending versus their benchmarks, but perhaps more importantly, how they did in improving the quality of care received by Medicare beneficiaries. Our guests today are Dr. Farzad Mostashari, founder and CEO of Aledade, a large provider in the Medicare Shared Savings Program, and Dr. Mann, one of the participants in a Delaware ACO that Aledade sponsors. So let's take it to the conversation. Today, we're joined by Dr. Farzad Mostashari, CEO and founder of Aledade. And the occasion... Okay. It's good to meet you. Welcome. The occasion today is the release by CMS of results from the Medicare Shared Savings Program for 2024, which appear to be very, very positive. Gross savings of $6.5 billion. All the good numbers are up and all the bad numbers are down. It seems like a banner year. But Farzad, I know you dive into these data very closely and follow them. Anything jump out at you?
Yeah, I think the fact sheet actually that came out, I thought was very helpful in highlighting what has been noted before: the total savings against benchmark, the improved performance year over year, the fact that physician high primary care and low revenue, meaning non-hospital mostly, ACOs do better. All of those are consistent with past releases. But what the fact sheet pointed out, I thought, in more detail this year was the quality improvements, and actually comparing quality of care in ACOs to, I think, the imperfect comparator, but to patients who are not in ACOs, and it's worse. And not only is it worse, but the ACO's quality is compounding over time. And I think that's a really important dimension to bring into this as well, whether we're looking at hospitalization rates, ED visits, which I think are hugely important, whether we look at quality and cost. And so it really points out that this program is delivering. It's delivering on the aim of getting lower cost through better care. Because there's lots of ways to get lower cost, right? You can cut payments to doctors. That's easy. You can cut benefits for patients. That's something you could do. But to simultaneously improve care, increase access, more primary care, and lower cost, and pay primary care docs more, like that has been, as you have pointed out, Sean, kind of the policy dream. And the question that I think we're going to get to is, well, what comes next and how do you grow from here?
Farzad, Aledade is the largest network of independent physicians in the country, taking care of over 1 million Medicare beneficiaries. That's a little more than 10% of the whole Medicare Shared Savings Program. How did Aledade do?
Well, we have we're still, as you said, we're only 11% or something of the lives in the program. But yes, we are in aggregate the largest enabler, not only of total, but also of people new to the program. We tend to bring in a very outside of our share of people who are new to the program. So bringing new practices into the program. And what that means is that we have a lot of folks who are early on in their savings trajectory. So we have our mature ACOs who've been doing this for now, gosh, almost 10 years. And I think our best performing ACO, Louisiana, has been at this now almost 10 years, 17% savings rate. But we also have a lot of ACOs who are just starting out. So our blended average savings rate was 7%. Pretty good. But that has to be understood in the context of a lot of relatively new cohorts. One of the things I was actually most proud of, though, was not the savings rate, and going back to what we just said about quality. It was on the measure that saves the most lives. And if you've been a listener to this podcast, you know what I'm going to say. It's blood pressure control. On blood pressure control, ACOs do significantly better than unmanaged fee-for-service. ACOs are improving. In the fact sheet, it said they went from 78% to 79.5% blood pressure control, which is actually pretty darn good. Aledade's average was 83.24%. So yay for Aledade, saving lives, doing good. So that is something that I was quite proud of. The other way to look at this was to look at the people. There are 11 million beneficiaries who could have been in an ACO if their primary care provider had signed up, but they weren't. And so they met all the other requirements, exclusion, inclusion criteria, eligibility criteria for the program. How did those 11 million people compare on these metrics compared to ACO's 11 million people? The hospitalization rate for those 11 million beneficiaries not in ACOs was 290 per 1,000, or 29%. You can think of it. Some people have more than one. MSSP assigned was 257, and Aledade was 236. So if you do the math on that, that's like, the difference is like 600,000 hospitalizations. That's extraordinary. And that's really something for this program to be proud of.
Farzad, you mentioned a couple of things ACOs don't do. They're not denying care. They're not cutting benefits. So how are they reducing these hospitalizations? How are they improving hypertension control? How are they saving Medicare money?
Yeah, the fact sheet talks about this, and our data certainly bears it out. It's lower utilization compared to their benchmark across many categories of utilization, including hospital discharges, emergency department visits, and if you don't go to the ER and you don't need to get hospitalized, then you don't have as many days away from home in skilled nursing facilities. So the way you get to decreased utilization across a whole broad range of those things is better prevention. It's better chronic disease management. It's more prevention. And we're seeing that play out. I think I mentioned our Louisiana ACO, right? 17.3% savings rate. And, it's not a surprise that our best performing ACO was number one in the country. Out of 476 ACOs in the country, they were number one for patients on the survey saying they were able to get a timely appointment. Right now, if you try to get an appointment with your primary care doc in a fee-for-service practice, even if you're an 86-year-old with congestive heart failure, it may be months. And the highest savings ACO gave patients the most access. They were number one in patients saying that they felt that their care was coordinated. They were number three in the country out of 476 on the survey for patients saying that my provider communicated with me, and in their rating of the provider as being a good doctor. These are not numbers you get from stinting on care, right? That's not how this program is achieving savings.
Yeah, I love it that when we talk about quality, you're bringing up hospitalizations and ED visits. We know that sometimes when people talk about improved quality, that can sometimes reflect how hard they looked in the medical record for something, or how well their electronic health record was connected to the health plan to pull the data. But if you're reducing ED visits, really the only way to do that is to make it so that people don't need to go to the ED through access and better preventive care.
Exactly right. No one wants to be in an emergency room for 40 hours. No one wants to be hospitalized. And there's no way to really stint on hospitalizations. If you need it, you're going to get it eventually. That's not how ACOs are getting savings. Now, you could argue, though, well, yeah, but overall, so what is this? It's a few $1 billion, right? A billion here, a billion there, right? $6.5 billion in savings against benchmark. And so, Sean, when you hear that as someone who used to run the Medicare program, that's 100 times that or something, right? What is your thought on like, yeah, but why isn't it more?
Yeah, that's the crux of the issue, the heart of the problem, in that the answer has multiple layers. We all wish the number was higher, and there are ways I think we believe the number could be higher. But before you get to how do you raise the number, let's put the number in context. So one context is, a couple billion in the context of the traditional Medicare programs, a couple percentage points, big deal. Well, two responses to that. One is the other half of the program, the Medicare Advantage program, despite its many strengths and its popularity, has, as MedPAC has repeatedly pointed out, never succeeded in its goal of saving Medicare any money. In fact, has overspent traditional Medicare quite substantially. MedPAC estimates $84 billion this year. So compared to that population, the savings are quite substantial. And then the second part is, in fact, the Medicare Advantage spending would be even higher if it weren't for the Medicare Shared Savings Program suppressing spending in traditional Medicare, where their benchmarks come from.
Let me say that back to you. What you're saying is the rate increase that Medicare Advantage plans get every year from Medicare, that's tied to cost increase in traditional Medicare. That's the reference population. And if ACOs are reducing cost growth in the traditional Medicare population, there is savings that is not reflected in these numbers. You can call it spillover or externalities or, but the actual savings would probably be twice what comes in here, something like that.
Oh, I think there's actually a much more substantial multiplier, in part because the Medicare Shared Savings Program is 10 million, 11 million beneficiaries, but Medicare Advantage is over 30 million. So you get the multiplier effect. And Milliman, the well-known actuarial firm, has written some studies on this.
Sean, just another beat on, could these numbers be misleading somehow? One of the reasons why there's a lot of overpayment, people, MedPAC has said, in Medicare Advantage is because of not improving care, but diagnosis documentation driving up the payments there. Could diagnosis documentation be behind these benchmark savings in the ACO program?
Now you're thinking like a CMS analyst. Good for you, Farzad. Because that would be the first question a smart CMS person would ask. And the answer, thankfully, is they're not driven by risk adjustment, because if you look at the aggregate risk adjustment that occurs in the program, what's called the risk ratio in Medicare Shared Savings Program, is essentially flat. Meaning some ACOs had higher risk ratios and some had lower, but in aggregate, essentially there was no risk lift at all. So, and that's because Medicare has gone to great lengths to not allow in the Medicare Shared Savings Program the problems that have occurred in Medicare Advantage.
All right, so we've knocked down some of the potential skepticisms in terms of these numbers, and I will say the earlier studies that have been done comparing the Medicare Shared Savings Program benchmark savings versus actual savings found that the actual savings in a kind of a rigorous academic study were higher than the benchmark savings. And I suspect that's only grown higher in part because the benchmark resets. So when I talked about our ACOs who've been doing this for 10 years, every time they have to reset, and you have to reset at least every 5 years, the sum of those savings get taken away that they've achieved against the counterfactual trends, and the benchmark is reduced commensurately. So I do think this is fine for now, right? Like the Medicare program is getting probably more savings than is realized on this piece of paper, and that's fine. We're helping the taxpayer. But I do think that as time goes on, we do need to think about the incentives to increase the savings rate in the program. And how do we make it so that if you get savings, you aren't it isn't taxed away, as it were, with the benchmarks and the ratchets and all the rest of it.
Right, that's high level. I'm going to bring us back to on the ground. For the second half of the show, we're going to be speaking with a physician who's been with Aledade for a long time, from a point where he was getting no shared savings to where there was success. And we'll hear how he thinks he did it. But Farzad, what's your take? You've mentioned that patients in an Aledade network may have greater access to their primary care clinician. There's a greater focus on high blood pressure. What else? What else works?
It's actually not that complicated, right? Before I started Aledade, I was at Brookings, and we created a learning network for physician-led ACOs and published the toolkit. Everything that I would say is what was in that toolkit 12 years ago. It's just we've gotten better at creating kind of technology that helps support people actually doing that at scale, reproducibly, whether it's Utah or West Virginia. And those four is the core four. We call them is access. So reach out to patients, trust. When we had a little dance party at Aledade, which we do every time the results are announced. No, the video is not available. But one of the themes that came out again and again from our market leaders, was trust the process. Trust the process. Do the things, do the right things, and good things will happen. And those are, reach out to patients who you haven't seen in a while. Make sure that we have at least one visit focused on prevention every year. When you see the patient, just be aware of what are the highest priority things you need to do to keep them healthy over the next year, whether that's screenings, whether that's blood pressure control, whether that's medication adherence issues. Third is the care transitions. When someone has been in the emergency room, they're at very high risk of bouncing back to the ER or hospitalized again. So connecting to folks during those care transitions. And then finally, you'll hear the wraparounds, where there may be targeted segments of the population that need extra help. And so whether it's patients with congestive heart failure or COPD, or who are going to need an end-of-life planning discussion, or help with their medications, those are some of the subsets that we wrap around the practices to achieve the savings rates.
I remember when I joined Aledade, and the company was about 3 years old, and I would go to meetings with Farzad and some outside groups, and people always, one of their first questions was always, so what's your clinical model, Farzad? And he kept saying, primary care, primary care. And I remember thinking to myself, oh, shoot, we don't have a clinical model. I should have done some more due diligence. But I mean, everything you just described is primary care. It's more targeted, better access. But if you read my former professor, Barbara Starfield at Johns Hopkins, who defined the ideal of primary care, it's just the stuff you describe is putting those principles into action and making them actionable.
I will say, at a time when it's never been easier to get an urgent care visit or a telehealth medicine prescribed by someone who's never seen you with some online pharmacy, it's super easy to do that. And it's never been harder to have an ongoing, patient-centered, longitudinal, caring relationship with a primary care doctor. And that's the problem we are here to solve.
Farzad Mostashari, CEO and co-founder of Aledade, thank you so much, and congratulations.
Thank you.
We are now joined by Dr. Sandeep Mann. Welcome, Dr. Mann. If you could start by telling us about your practice. Where are you? What type of practice it is? What's the name of it?
Sure. I'm Sandeep Mann. I'm a primary care physician in mid-Delaware. We are practicing in Delaware Primary Care in Dover and Milford. We started about 25 years ago. Actually, Bay Health gave us an award last year for being 25 years in the area, and we are six providers at this time, four physicians and two nurse practitioners.
So you've probably seen the numbers for how you did last year. Earlier in this podcast, we had Farzad on talking about how the Medicare Shared Savings Program did in total and how Aledade did in aggregate. I understand it was a pretty good year for you. Do you want to describe how good of a year it was for you?
It was a great year. We did really work hard for it. It brings in a significant amount of our income from Medicare. I don't have the exact number, but it is close to somewhere around $700,000+ for our practice, which helps us not only give bonuses to our staff, to give bonuses to our physicians, to put investments in our infrastructure in the office. So and that increases our revenue significantly for Medicare patients, which would not have been possible just for fee-for-service model that we were using before.
Yeah, I don't know if this is accurate for your practice, but some of our calculations show that in aggregate, our Delaware practices make more for Medicare through shared savings than they bill fee-for-service. I don't know if that's true for each individual practice, but it's a pretty remarkable accomplishment.
I think it's totally unbelievable. If somebody asked me this 10 years ago, I would be laughing at the face, but it is true, and it is remarkable what the new model has proven, that saving money can actually improve the bottom line.
Dr. Mann, you've been with Aledade for a while now, is that right?
Yeah, we attended Aledade meeting when they came to Milford when they started, and we were the first few practices that started, joined them. I think we were in the second year.
What made you want to join?
That was a time when the ACOs were coming up, and we had been approached by different ACOs before, and what I found was that we were not sure what they were going to provide us as a practice, and we were sort of afraid to join an ACO which we would repent. And the feedback we had gotten from some other practices who had joined an ACO in Chesapeake, even though they were giving them money when they joined, was not very positive. So we waited until we had the meeting with Aledade in Milford, and we really liked what they said, what they were representing, and how they were going to help our practice. And even though at that time, I still remember we were going to pay per month fees, we thought that was a better deal for us long term.
So you liked what we said back then. What's your actual experience been over the past almost 10 years?
It's been great in the last 5. It was not the best in the beginning. It took us a while to get on the right track. I think that was just a learning curve for us as well as for Aledade. But I think everything was worth it in the end, because what we have shown is that not only we have improved patient care, but we have saved Medicare and other insurance a lot of money.
So you said you were paying to be part of Aledade. That was part of Aledade's initial strategy. We thought it would help people be more engaged if they had to pay, but turns out people can be quite engaged if they don't, and there are no monthly fees now. So you were a practice that was part of the ACO when there was no shared savings, when there was not success, and as you say now there is. When you talk about the learning curve, what was it you think you had to do differently to win?
It's like several areas where we were lacking behind. So we were taking care of a sicker population without identifying them. Secondly, to change our habits, we were a practice which was mainly doing fee for service, and now we have changed our whole routine to preventive care and population health. So it took a while to get used to the new workflow and to train our office staff and the physicians to follow that.
You go a little deeper on that when you say changing workflow and changing your orientation. So in a really tangible way for our listeners, what is different today than prior to being in an ACO?
Before we started, the income we brought in as a practice was based on what we saw as a practice, the number of patients we saw, how many patients we saw. We were actually looking for doing procedures to generate income because our income was not enough. We didn't have per month per user fees, which we have now. And we were, as a primary care physician, we were doing so much stuff for our patients, we were not billing for that. So all that changed with Aledade coming in. It provided us a path to improve our not only service to our patients, but in methods which was more beneficial to the practice and the patients. So our push to Medicare annual physicals started, transitional care visits started, patients who were going to the ER, their follow-up started, calling patients who were not showing up, which we didn't even know because nobody followed that, nobody tracked that. All those things improved our practice, improved our patient care, as well as increased the finances, improved the finances that we were getting paid for.
Delaware is actually known as a state where primary care clinicians struggle, that the insurance reimbursement rates are quite low. So it's great to hear that doing this preventive care has increased your revenue. Has it been a substantial difference?
Yes, it has definitely improved a whole lot. We look forward to our shared saving check every fall. It's still something that we would not be able to survive without. And the reason is because the primary care has been squeezed in Delaware for a long time. That's hopefully changing.
Dr. Sandeep Mann of Delaware Primary Care, thank you so much for joining us, and congratulations on the success of your hard work.
Thank you, and thanks to Aledade for everything.